Yeah, am I audible?
Yes, sir, you're audible. I'm able to see also.
Okay, okay. Okay, so hello everyone. We'll be going to start discussion on infections OSCEs. We'll try to guide you as much as possible. We'll be very happy if we have active participation from your side as well. It makes the discussion more better. Okay. Okay.
Yeah, yeah. So we'll start with the first scenario. So here we have a 24-year-old pregnant woman who is in her second trimester of 20 weeks gestational age. So she presents with fever, chills, and weakness. The peripheral smear shows a Plasmodium vivax infection. So this is now a case of malaria in a pregnant female. So, what will be the first treatment, different pharmacological treatments, and what will be the drug of choice? So, if anyone can tell, that will be very good. Anyone wants to answer? Simple first question: malaria in pregnancy. So, what are the different anti-malarials and what should be given here? Okay. Anyhow, okay. So, we shall go forward, sir, if you like.
Yeah. Okay.
So yes. So if you look, so what is the different anti-malarials that we have? So we have chloroquine, we have artemisinin or other artemisinins, and we should use that ideally in artemisinin combined therapy or ACTs. We have, of course, quinine, good answer on the chat box. And also we have others like doxycycline, clindamycin that we have, atavocone and others. So lumefantrine even. So simple to say, the safest anti-malarial is chloroquine. So that has been studied and can be given in any trimesters. But the problem is when you have a severe malaria or a complicated malaria, be it with Vivax or falciparum, or if you reside in areas where chloroquine resistant is prominent. So in India, of course, chloroquine resistance is prominent. So there you look for the alternatives. The first ideal choice, if it is not pregnancy, is artemisinin combination therapy. So, but in the first trimester, it has not been studied much, and some animal studies have shown to be harmful. So, that is why in the first trimester, the other alternative, like quinine, is the preferred choice. But if you look at the latest WHO guidelines after 2023, they said even in the first trimester, if it is a complicated infection, when you don't know if quinine or chloroquine is going to work, better the preferred first line of choice is still artemisinin based combination therapy, even in the first trimester. So here, actually, if it is at the second trimester, there is no problem. Even in Vivax, we can sometimes see complicated infections. So there again, ACT will be your first choice. Other than that, the question comes with Vivax next is radical cure. So for Vivax, you will always have the problem of treating it with primaquine later on for the hypnozoids so that you don't have relapse of malaria. So when you are in the second trimester, primaquine is very dangerous to be given during the time of pregnancy. It can lead to serious neural tube defects. So that is why it is ideally to be given only after delivery, that too not while breastfeeding. So these are important precautions to be given while taking primaquine. But again, what will happen? So should we delay it till delivery? So what will happen? Meantime, there can still be relapse. So it is generally they are continued on chloroquine prophylaxis till the delivery, or some people even up to 6 months after delivery, chloroquine can be continued, and then they can take the primaquine to complete the total course of for the radical cure and complete the treatment for Vivax malaria. Okay. So that is how ideally pregnancy is treated. Malaria is treated in pregnancy. So if you have any doubts, you can ask or you can put in the chat box as well.
Sir, and the chloroquine dosage, sir, after the treatment, what will do about the
Uh,
dosages after the
Dosage
acute
is
therapy?
uh, after the prophylactic dosage is less. The commonly what we use is 50 mg or 100 mg is enough actually. But what is nowadays chloroquine actually is not available, and it is difficult to procure chloroquine other than others. So 150 mg is more commonly available. So it's half 75 mg also can be given.
Okay, sir. So it is given weekly, sir, or daily we have to give after the acute therapy?
After the acute therapy, daily at a low dose for prophylaxis. Weekly
Prophylaxis.
prophylaxis is for travel prophylaxis. That is against.
Uh, Okay, sir. Okay, so I hope sir has cleared it well. So malaria and pregnancy. Okay. So let's go to our second case. Sir, you can continue, sir.
Yes. So here we have a 25-year-old male who presents with a 5-day history of intermittent fever, chills, and profuse sweating. And this is accompanied by headache and fatigue. So he reports a recent trip to a malaria endemic area as well. And his examination also reveals pallor and splenomegaly. So the blood smear confirms Plasmodium vivax infection again. So here again you need to give cure. So you will treat with ACT, and then for radical cure, primaquine is indicated. But here the patient also says he is a known case of G6PD deficiency. So how will you manage? Will you give primaquine in this case, and how to give? If anyone can answer, that will be.
Yeah, anybody who want to answer? So patient is a case of Plasmodium vivax and his G6PD deficiency is there. So how will you give him the radical cure? That's what sir is trying to ask here. Okay. So will you give? So first question is, will you give primaquine or you will not give primaquine to this patient? Yeah. So many are saying no in the chat box. Okay.
Right.
So then how will you
So
give? Do you have any other alternates then? Other than primaquine, can you give any other alternates then?
uh, actually primaquine is the best when it comes to acting on hypnozoids. So
Yes.
we'll see there are actually state deficiency can be mild, moderate, or severe. So based on it there are different recommendations for primaquine actually. So primaquine, that there is also reduced dose of primaquine that can be given in moderate deficiency. So you can actually do G6PD deficiency in a quantitative manner and actually assess the enzyme activity. So if the enzyme activity is less than 10% of what is actually required, then it is called a severe G6PD deficiency. And there, primaquine is contraindicated. You should try to avoid. For more mild to moderate or for 60 to up to 10%, you can still give primaquine because the chance of hemolysis is almost 1 to 2% in those patients, even with primaquine at that rate. So their primaquine can be given at a slightly reduced dose here. So weekly doses for up to 8 weeks rather than a daily regimen.
And what
So
about Afinoquin, sir? Do we have it available, sir, in
yeah,
India?
Tafenoquine for India as of now, no. So Tafenoquine, so the problem with radical cure is taking the daily for 14 days, another after discharge. So most of the time it is not possible, and these people continue to transmit the disease. So that is why an alternative single dose regimen was introduced recently by the name Tafenoquine. So this being a long-acting drug, it led to very high chances of hemolysis, especially even in mild G6PD deficiency patients. So here it is very important when you are using tefenoquine because it is very high long acting and its action cannot be stopped. You should definitely check for G6PD deficiency. As of now, this is not available. So it is definitely contraindicated in even in moderate. You need to be careful when using tefenoquine because it's very long acting. It acts up to almost 20 days.
So okay, so I think sir is clear and this question is cleared for the students. Okay, okay, so we'll go to our next question.
So the third scenario, we have a 30-year-old male who presents with a 5-day history of high-grade fever, headache, retroorbital pain, and myalgias. He also now he started having severe abdominal pain, persistent vomiting, and also mild gum bleeding. So on examination, his blood pressure was on the lower side at 100, systolic 100 and a diastolic of 70, with a pulse of 110 beats per minute. Laboratory tests also reveal a low platelet count of 45,000 and a rising hematocrit. So, what does this the overall picture suggest of, and what could be the probable diagnosis in this patient? Consider it. This is also happening immediately after the monsoon season.
Yeah. So anybody who wants to answer here?
Yes, we have a chat answer saying as dengue hemorrhagic fever. Okay, nice. So, is it still the definition as dengue hemorrhagic fever? So you can look into it. The definitions of dengue have been changed. It's dengue with warning signs, and severe dengue. Dengue hemorrhagic fever per se has been removed for now, but still, yes, definitely very good answer saying it as a dengue. The likely and what features? So, what do you think is the exact features? Actually, this is a classic presentation where you have high grade fevers associated with myalgia, retroorbital pains, and he is also having some danger signs that as like. So, what are the danger signs that one can see in dengue? So here anyway, he's having. So next slide, I think we have the danger signs. Uh, Yes. So there is a specific list. All the features may not be the danger signs or the warning signs. You need to go through exactly what are the variable signs. See, raising hematocrit and gum bleeding, these are definitely the clinical features, but they are not that actual warning signs. Important warning sign is actually someone has put up as abdominal pain. So that is one of the important warning sign, and of course bleeding. Severe headache, again, I think that can be present, but still that is not per se a warning sign for dengue. Sir, if you can share, I'm not able to see the screen. I'll be sharing my screen.
Yeah. Hello.
Sir, you can share. You can share.
Yeah. No issue.
Yeah. Yes, definitely increased hematocrit is what we follow, but it is not per se a warning sign. The important warning signs: abdominal pain, persistent vomiting, clinical fluid accumulation, third spacing of pleural effusion, ascites, and then bleeding, be it simple mucosal bleeding or any severe intracranial bleed, GI bleed, etc. And next, restlessness, lethargy is one. I think donor and hepatomegaly, and even we also have some of the investigations like raised AST and ALT. And why is hematocrit important in dengue management? See, the main problem with dengue is to maintain the intravascular volume because of the high grade fevers, serositis, and the third spacing that happens because of the leaky vessels. So that is why the intravascular volume is low and your hematocrit rises in dengue. And that is one of the important features that you need to maintain the intravascular volume. And hematocrit is mainly your target for your IV fluid therapy. And that is what the most important treatment that you give in patients of dengue, which is IV fluids. And for it, the therapeutic target is the hematocrit. So that is why hematocrit is the most important thing that you need to see in a dengue patient, even more important than your platelets. So, what are actually the indications where platelet transfusion is necessary in dengue? See, all patients of dengue do not require platelet transfusion, even though they fall very less. So they say even up to 10,000, they say some may prefer to give as a prophylactic measure when platelet falls below 10,000. But even then, the harms and benefits are still dicey. Less than 20,000 if there is minor bleeding. So the presence of bleeding is a more important factor for platelet transfusion rather than just looking at the platelet count. And presence of minor bleeding with less than 20 and any active or bleeding with any platelet count is possible in dengue, and there also you might transfuse platelets. So for invasive procedures or surgeries, you should try to maintain, or emergency surgeries is ideally right. So if surgeries are required, you should try to maintain the platelet count more than 50,000. And in pregnancy, especially in early pregnancy, to uh, prevent placental bleeds or intra uterine bleeds, we should try to keep the platelet counts more than 30,000. Okay. So other than this, just simply giving platelets for any other reason prophylactically is generally not advised. Okay, can go to the next question. So for the next scenario, fourth, we have a 32-year-old farmer now who presents with a 5-day history of high-grade fevers, chills, headache, muscle pains or myalgias, especially in the calves areas, and also red eyes. He also mentions that he worked in the recently flooded fields. So on examination, he is febrile with 101 degrees Fahrenheit. He has conjunctival suffusion, that is why he is having red eyes. He also is found to have mild jaundice, and there is tenderness in the right upper quadrant. And his urine output is started to decrease in the last 24 hours. Lab diagnosis revealed elevated creatinine and also bilirubin with 4.2, and all thrombocytopenia, which is mild with platelet count of 90,000. So this, so what is the clinical features likely suggest? So there is hepatorenal dysfunction, there is platelet decreased platelet counts, and you also have a recent history of flooding, conjunctival suffusion. So what could be the diagnosis? Good, leptospirosis is one of the common. So it is especially common in the western side. You will have a lot of cases, and if it is there, they will try to keep it. Okay. Next, the question here is: so what is the other name, if someone can tell, of leptospirosis? Okay. Anyhow, we'll see. Yes, Wheels disease. So that is the disease caused by leptospira, specifically called Wheels disease with jaundice. So, what would be the investigation that one would test to confirm the diagnosis? For leptospira, what is the common investigation? So, you can test the serum, you can test the urine, and in serum, antibody, and more than antibodies, IgM always can sometimes be false positive. So, the definitive will be to identify it by a PCR. So, that will be more specific. But of course, IgM will be is the most common that we use. And even urine, we can also directly demonstrate the leptospira as well in a dark field microscope. So the diagnosis here is definitely leptospirosis. Supportive clinical features will be the fever with muscle pain. Conjunctival suffusion in leptospirosis in hepatorenal dysfunction is one of the pathognomic feature when it comes to leptospirosis. And then you have jaundice, acute kidney injury, and recent exposure. Of course, flooding is one definite risk factor. So leptospira, one can acquire leptospira. So it is mostly during flooding that your water keeps gets polluted with rats urine, and then you can easily acquire the leptospira. So the definitive test will be PCR and microscopic agglutination test for the antibodies, which is actually more specific, but that is not usually available when you do IgM. And also, urine also can be done with dark field microscope. So the next question. So manage, what will be the drug of choice for leptospirosis? Yeah, that is what is commonly used. But when someone says the drug of choice, the one answer that should come for leptospirosis is penicillin. Ceftriaxone is only an alternative to penicillin because it is now become not that easily available. But penicillin is a drug of choice when it comes to leptospirosis. And only oral doxycycline is advised, or even not even oral. Doxycycline is advised only for mild cases. Severe cases, penicillin or its alternative ceftriaxone, and not higher anti beta lactams, not your beta lactam inhibitors, not meropenem, not higher. They are not going to work. Only the primitive beta lactams, penicillins up to ceftriaxone will only work, not beyond them. And of
Okay,
course the
sir.
support care, IV fluids and all, and the possible complications. So leptospira, if left, definitely it can lead to complications. The most earliest sign will be someone with having pulmonary hemorrhage and ARDS. So the Wheals disease is generally given for those with jaundice, renal failure, and bleeding. Meningoencephalitis is one complication with leptospirosis, and of course, if left untreated, it will lead to multi-organ dysfunction. So for the fifth scenario, we have is a 35-year-old male who presents with history of significant weight loss, chronic diarrhea, and a low-grade fever for the past 3 months. So he was diagnosed with HIV infection 6 months ago and has not been started on antiretroviral therapy. His recent CD4 count is 150 cells per micro. So he appears cachectic, and on oral examination, candidiasis is also noted. So here, what is likely the stage of his HIV infection? So how many stages are there in HIV infection? If anyone can tell and what is the stage, that would be good. And next, we'll also discuss what are the prophylactic measures to be initiated at different CD4 counts. Then discussing about oral candidiasis, and also when should ART be initiated. If anyone can answer the first question, that would be good.
Okay, sir. I think we can continue, sir.
Yeah, yes. So there are actually three stages of HIV. So the first will be actually the acute stage, three or four. Four is also acceptable. WH says 3, Harrison says 4. You are good if it says 4 also. So the first is acute, and then chronic infection, and then symptomatic, and then severe infection. So, but all define severe HIV as CD4 less than 200 or advanced HIV disease with CD4 count less than 200. Okay, and so we can go to the next slide. Yeah. So the advanced HIV or the stage 4 is when you have CD4 count less than 200 with increased risk for opportunistic infection. So irrespective of CD4 count, if you have some of the opportunistic infections, it is considered as advanced HIV. So these are called cardinal opportunistic infections. Okay. So for CD4 count of less than 200, they can present with pneumocystis jirovecii pneumonia or PCP. CD4 count of less than 150, they can present with disseminated histoplasmosis in the endemic areas. Less than 100, toxoplasmosis, especially talking about CNS toxoplasmosis and CNS cryptococcosis in patients with CD4 count less than 100. Less than 50, they are the most prolonged disease that they are having. CMV retinitis is one of the characteristic feature. You can also have Mycobacterium avium complex or other NTM pulmonary infections. So these are characteristic opportunistic infection that can be seen at specific CD4 counts. Okay. So yes, next question. So the prophylactic measures. So for to prevent some of these opportunistic infections in HIV patients, we use antimicrobial prophylaxis. So the preferred antimicrobial prophylaxis is cotrimoxazole or trimethoprim sulfamethoxazole, which is the combination that is given. You use a double strength tablet, which is 960 milligrams, 800 of trimethoprim and 160 of sulfamethoxazole. So that is one tablet of double strength tablet. You use that one daily to prevent any opportunistic infections, especially when CD4 count is less than 200. So sometimes it is given, if you look at the recent NACO guidelines, they even say at less than 350, you can start cotrimoxazole prophylaxis because there have been some death benefit to prevent in giving cotrimoxazole prophylaxis in these patients. So yes, that should be enough. For less than 50, you also add MAC prophylaxis. But it's generally said that when you are initiating ART, you no need to add per se azithromycin if required. But if you're not initiating ART, it's better you add weekly azithromycin as MAC prophylaxis when CD4 count is less than 50. Yes. So what will be the treatment for oral candidiasis? So the candidiasis, the first line is uh, oral antifungal called fluconazole. So here you should give 100 to 200 milligrams given daily for 7 to 14 days. The first dose should be preferably 200 milligrams and orally you can give it for 7 to 14 days. You can also add it on with clotrimazole lozenges or the commonly called candid paints. Next. So when should ART be initiated? For any HIV patients, ART should be initiated as soon as possible. So there's only one answer, as soon as possible. So why should we even delay ART? So sometimes it is possible that some of the immune system immediate reactivation of an immune system can be deleterious. So in some of the opportunistic infections, so there you may want to delay the ART. So depending on the infection, you can sometimes delay. But you have detected a HIV patient who is asymptomatic, doesn't have any opportunistic infections now that is life-threatening, you can definitely start your ART immediately, irrespective of the CD4 count. Next, I think next we have the scenario where you actually need to delay. So we'll discuss here more about delay. So here we have a 36-year-old HIV positive male who started on ART 3 weeks ago. and then he had previous history of tuberculosis and was initiated on anti-TB therapy 2 months prior. So 2 months after, he was actually almost 1 month after, he was started on ART after starting ATT. So now again he presents with worsening cough, fever, lymphadenopathy, and night sweats. So there is cervical lymphadenopathy. There is also consolidation in the right upper lung field. A CD4 count is 50 cells at the time of initiation of ART, and his viral load is significantly decreased. Now, when he is tested, his viral load has decreased just 3 weeks into initiation of ART. So, what will be the likely diagnosis here, and what is the mechanism behind it? So, if anyone can answer, that will be very good. So just to simplify it, so 36-year-old male who was first diagnosed with TB, he was started on ATT first, and ART was delayed initially. 1 month later, was started on ART. At the time of ART initiation, his CD4 count was 50, and maybe his viral load is high. And after ART, 3 weeks later, his viral load has significantly decreased, but he started having these new symptoms. So this is what is called iris, or immune reconstitution inflammatory syndrome. So that is the likely. So what is the pathology here behind it? So, and who are more prone to develop iris? So let's discuss. So iris is when, so now because there is rapid reduction in the HIV viral load, immune system gets boosted. So immune reconstitution happens very fast. So now your immune system is activated, and it acts on infections that are present, or previously, if someone is known, that infection can flare up, or previously if something is not known, that can manifest now, because your immunity system is acting against it. Okay. So this can be seen with TB, cryptococcus, any other opportunistic infection that you can think of. So next slide has a better. So yes. So these are the two important clinical types of iris, which are paradoxical and unmasking. So paradoxical is when they already have the symptoms of the opportunistic infection, and now you started on ART, and the symptoms have aggravated. So this is mostly because of the immune system acting against the opportunistic infection. So that is paradoxical iris. So in unmasking iris, the usual situation is you think they don't have any opportunistic infection. You start them on antiretroviral therapy, and 2 to 3 weeks down the line, when their viral load falls down and their immune system recovers, they come now with symptoms of an opportunistic infection like cryptococcus or TB. So that is when the actual opportunistic infection is unmasked, because your immune system is acting against us. So that is unmasking iris. So how will you differentiate iris from other causes of deterioration? So of course, other possibilities are definitely there at this point. So first important thing is you need to differentiate it from ART failure. So here viral load is important. So when you check the viral load here, when patient presented with worsening symptoms, it has actually decreased. So that itself says that your ART is acting good, and your immune system actually has improved. So that is why it is more likely to be iris rather than failure of your ART regimen. So drug resistant in TB, that is possible. So for that you need to test for the drug resistant. You need to see repeat the test for TB, and look if there is MDR tuberculosis. Of course, it is possible that you are treating the patient for TB, and now the patient comes out to be having PCP also. So there can be other opportunistic infections that can be present, that can manifest now. So you need to be looking for them as well. And drug reactions. Of course, patient has been started on ATT and ART. There can be interactions, and you need to see if there is these drugs are correctly. There can be ATT related problems like hepatitis and all. So these things again have to be checked whether those adverse reactions are causing these problems or not. So iris management, see, it's mostly you need to continue the ART and ATT medications. So this is just an immune reaction to the thing. You need to let it calm down. So most of the times it is mild or moderate kind of immune reconstitution. You need to reassure the patients it will be okay. Your viral load is good. You don't have any drug resistance. Keep continuing the same medications. Don't stop them. You will get better. 90 to 95% of the time, that is what happens with iris. But some may have severe iris, especially in case of something like pulmonary TB going into ARDS or TB meningitis going into worsened hydrocephalus. So these severe iris where you might need to use corticosteroids at a low dose of prednisolone 1 to 1.5 mg per day per kg per day for 1 to 2 weeks. Generally, this is what is given for pulmonary TB. For CNS TB, you give it for a longer time, and you will monitor for the complications due to iris and also the steroids. So when you are giving HIV patients steroids, again the risk for infections increases further. So the next question. Yeah. So for HIV, if you have any other doubts regarding any other, you can just put it up in the chat box. I will try to answer later. And next, we have the scenario where a 40-year-old male who is undergoing treatment for pulmonary tuberculosis with a standard four-drug regimen of isoniazid, rifampicin, pyrazinamide, and ethambutol. Now he presents after 2 weeks with worsening fatigue, nausea, abdominal pain, yellowish discoloration of the eyes. He is icteric and there is tenderness in the right upper quadrant. Laboratory findings reveal elevated liver enzymes with an ALT of 250, AST of 300, and a total bilirubin of 4.5. So, what is the likely diagnosis here? And what is the most common drugs responsible for this kind of condition? Okay, so we'll go ahead. So the diagnosis mostly a TB drug-induced hepatitis, likely secondary to anti-tubercular drugs. So among the four first-line anti-tubercular drugs, INH, rifampicin, and pyrazinamide can lead to hepatitis. Pyrazinamide is one of the most hepatotoxic, but the pyrazinamide hepatotoxicity is mostly dose-related. So as you increase the dose, the chance increases. Next comes rifampicin. Rifampicin, it is mostly cholestatic type of pattern that you see along with raised OTPTs. INH, you see morely only raised transaminases and it can be mostly idiosyncratic and it doesn't have any relation with the dose that you give. Okay. So next. So when you should define that it is drug induced or TB drug induced hepatitis, your AST or ALT level should be more than 3 times and patient should be symptomatic. If the patient is asymptomatic, the ALT AST level should be more than 5 times the upper limit of normal. Hyperbilirubinemia with a bilirubin of more than 2 milligram per decimeter individually can also indicate TB drug-induced hepatitis. The clinical symptoms that one can present with are fatigue, nausea, vomiting, abdominal pain, and jaundice, and also temporal relation with starting of ATT. So generally, 2 weeks into starting, 1 to 2 weeks into the starting of ATT, patients can have what is called as the hepatic adjustment or the hepatic modification. So after trying to adjust to the new drugs, they can decrease by itself. So that is when most of the times you can see patients presenting with raised OTPTs or drug-induced liver injury. Next. So how will you manage? So we'll stop all the hepatotoxic drugs. We'll try to maintain the regimen using alternate medications like streptomycin. and then you manage it as a case of acute liver failure. That if it is present or not, you need to check for the other parameters like INR and these all, and then monitor it accordingly in the guidelines of acute liver failure. You need to rule out the other causes of acute deterioration of liver transaminitis as well. Next. So when would you reintroduce? So once the liver enzymes have normalized, then you can start to reintroduce the drugs, this time one after the another. So is there a specific way that you need to reintroduce? So there are different things given by different guidelines. The British guidelines, the American guidelines, and also Indian guidelines say differently. What I usually follow is start with pyrazinamide, because that is mostly likely not the cause, and usually if it is the cause, you'll detect it early. Because what happens in patient is happy for 2 to 3 weeks, he doesn't come back when he's a problem with pyrazinamide. So the most hepatotoxic drug I try to give it first, and then goes slowly with the adding the other drugs. Okay. So pyrazinamide, maybe then rifampicin and INH. Modified. So when you are trying stopping rifampicin for any case, if it is rifampicin that is causing the drug-induced hepatitis, you should try and compensate with a longer duration of up to 9 months of ATT. So for the next scenario, a 45-year-old male with a history of mitral valve prolapse presents with a 3-week history of intermittent fever, fatigue, weight loss, and shortness of breath. On examination, he is febrile, splinter hemorrhages on the nails. There is a new systolic murmur at the apex. The blood cultures are pending, but the transthoracic echocardiography reveals a mobile vegetation on the mitral valve. So this is a case of most likely a case of infective endocarditis. So the next question is, what is the modified Duke's criteria? You have the major and the minor criteria, and also if you have, you also, if someone mentions the definitive criteria as well, that one should keep in mind. Uh, Next, and how would you manage this patient? So you start with the empirical antibiotics and surgical intervention wherever required. So your choice for empirical antibiotics in native valve endocarditis or ceftriaxone plus vancomycin. For prosthetic valve endocarditis, it is vancomycin with gentamicin and rifampicin. Okay. Yeah, so here we have a case, MRI that shows ring enhancing lesions with some perilesional edema in the flare. Okay, so there are multiple ring enhancing lesions. These appear to be more than 2 centimeters in size, and there is perilesional edema around it. So suppose this is in a case of retropositive patient with a CD4 less than 50 having oral contagiasis. The most common thing will be a case of cerebral toxoplasmosis. So the supportive clinical findings, as I say, will be CD4 less than 100 in a retropositive patients. We'll have multiple ring enhancing lesions on a contrast enhanced MRI. Next. So of course there will be different differential diagnosis when it comes to ring enhancing lesions. When the CD4 count is less than 50 or 100, cerebral toxoplasmosis is definitely important. The others will be tuberculomas, cryptococcal meningitis. In non-infective part, primary CNS lymphoma, PML or progressive multifocal leukoencephalopathy. We can also have brain abscess, but these generally don't cause ring enhancing lesions. Of course, the other causes like NCC and these all can also be present as much as in normal patients. Yes, next. So the treatment for toxoplasmosis will be pyrimethamine and sulfadoxine. What we usually, because the availability of this is less. So we normally use cotrimoxazole or trimethoprim sulfamethoxazole, both for treatment and prophylaxis. Treatment you will have at a higher dose of double strength tablet twice daily, and prophylaxis once daily would be enough. So, one of the important risk factors, especially when it comes to pregnant females, so how can one contact toxoplasmosis? Is with exposure to cat feces or the litter box hygiene. So now people are adopting cats a lot, so they have to be careful, especially when they are pregnant, so that they don't acquire the toxoplasmosis. Otherwise, congenital toxoplasmosis is also becoming nowadays a major problem. Okay. 28-year-old healthcare worker who sustains a needle stick injury while handling a blood sample from a HIV positive patient. So the patient's HIV viral load is detectable and the healthcare worker's vaccination history for hepatitis B is incomplete. So the exposure occurred 2 hours ago and the healthcare worker presents to the emergency medicine. So immediate management for needle stick injury. So the more three, there are not only three, but the important three viruses that can be transferred are HIV, HBV, and HCV. For HCV, you don't have any post-exposure prophylaxis. For HBV, you have vaccinations. For HIV, you have oral drugs. So the immediate management for any needle stick injury is to clean the wound if it is there, clean it with soap and water. But that can sometimes increase the uh, blood flow and increase the chance of error. But it's still okay to clean it with water and not with alcohol. Next. So wash the thoroughly with soap and water. Avoid squeezing or scrubbing the wound. Type of exposure, of course, depth and hollow bore needle, which is mostly the common case where you have bleeding and you have use a hollow bore needle. Patient status, you also check for HPV and HCV of the patient when it is known. When it is an unknown needle stick injury, you have to consider all three possibilities and go. Next. So the recommend PEP will be for HIV will be to initiate it within 72 hours, ideally as soon as possible, be it within 1 hour, 2 hours. The preferred regimen now is with tenofovir. What we have here is lamivudine and dolutegravir. It has to be taken for 28 days. The baseline HIV testing and HIV test should be repeated at 6 weeks, 3 months, and 6 months. So, till the end of 6 months, you cannot tell that they are completely free from what happened 6 months ago during the needle stick injury. So, getting follow up testing at 6 months is also very important. Next. So, additional prophylaxis. So, regarding HPV, since we don't know if he is non-immune, you need to give immunoglobulins and also start the HPV vaccine. If he is known immune and if he has known that his anti-HPV titers have been more than 10 at least once, so he is good and he doesn't. If the vaccination is incomplete, you can only start continue to give the vaccine or complete the schedule or restart the schedule, and that should be enough with patients who have incomplete vaccination or don't know the titers. So next scenario, we have a 7-year-old child who is brought to the emergency after being bitten by a stray dog on the leg while playing in the park. So the bite has broken the skin and the wound is bleeding. The parents report the dog's vaccination status is unknown. The child has not received any prior rabies vaccination. So the immediate steps that should be taken for the wound care in this case. What is the recommended post-exposure prophylaxis for rabies and the WHO exposure categories for rabies that you need to know. Okay. So for the immediate steps to be taken, again, it is important that you wash the wound with soap and water for at least 15 minutes. So that at least soap is a very good antiviral, and if at all any virus is present there overhead, and that would go away. Okay, and antiseptic application is generally not recommended, but if it is available, you can use. The important thing is immediately you should try to avoid the sutures without properly cleaning the wound. After cleaning the wound, it is okay to suture. It is not a complete contraindication. It is okay to suture. Next. So the recommended post-exposure prophylaxis will be now only 4 doses of rabies vaccine is given. Previously it is 5, and this is when it comes to the intramuscular deltoid. You also have the intradermal regimen where it is two doses at a 5 time dosing. So that is again different. Okay. For intramuscular deltoid, that is the preferred regimen. We give 4 doses at 0, 3, 7, and 14. Rabies immunoglobulin where it is required for category 3 exposures that we'll be talking about. Human rabies is what is available, rabies immunoglobulin is what is available now most of the times. So there you give it as a dose of 20 international units per kg. You need to infiltrate as much as possible, if not completely, around the wound and remaining at the nearest intramuscular site. TT also should be administered depending on the child's immunizing status. So if he has received a TT dose in the last 5 years, so that should be good enough. If not, revaccinate. Next. So WHO exposure categories for rabies are here. Important category 1, 2, and 3. So for category 1 is just touching or feeding the animals and your skin is intact. So there is no breakage on the skin and the animal may leak as well. So here post-exposure prophylaxis is not required. Intact skin is one of the most important thing that is done in category 1. In category 2, even if there is leaks or some uncovered skin is there, even if there are minor scratches or abrasions, still there is a chance of rabies infection. Here, vaccine is definitely recommended. In category 3, where there is a bite a little deeper beyond the dermis, where there is contamination of direct exposure with mucous membranes, where there is breakage along with bleeding, their immunoglobulin is also recommended because it comes under category 3. Next. So a 60-year-old male presents with a 5-day history of fever, productive cough, yellowish sputum, shortness of breath, pleuritic chest pain. He has a history of type 2 diabetes. On examination, his temperature is 101, respiratory rate is 24, saturation is less than 90% on room A. Auscultation reveals crackles in the right lower zone. X-ray shows consolidation. So mostly it is a community acquired pneumonia in a patient with comorbidities. You can consider severe community acquired pneumonia. So how would you perform? So the next, to define the severity of community acquired pneumonia or whether patients require inpatient or outpatient, you look at the curb 65 score. So this is something you do with a single blood test examination and also blood test. If there is confusion, raised urea, increased respiratory rate, low blood pressure, and an age. So if it is coming under high risk, you need to admit under ICU. Moderate, you require hospital admission. 0 to 1, you can consider for outpatient treatment. Next. Next. Sir, is it done? Oh, it is the next scenario. Okay, sorry, sir. Okay, so we have a 40-year-old male who presents with 10-day history of fever. This is right upper quadrant pain and malaise. So he has a poor appetite and reports a recent history of diarrhea. Laboratory investigations reveal leukocytosis. mildly elevated liver enzymes, and ultrasound shows a 6 centimeter hypoechoic lesion in the right. So the possible types of liver abscess, mostly two, you have pyogenic and amoebic liver abscess, that is important. So here the aspirate has been done. So the aspirate here is likely the color of what we call as anchovy sauce. So this is more characteristic of a amoebic liver abscess. Okay. So to confirm the diagnosis, you need a complete blood counts, LFT, serology of entamoeba histolytica can sometimes be present but sometimes can be absent as well. Ultrasound will confirm the presence of abscess, how many they are there, and whether there is any complication like rupture or not. CT scan, if required, you can do. Blood cultures important in pyogenic abscess. Aspiration is most important, and you can send it for direct mount to look for the trophozoites and also bacterial cultures in case of pyogenic. Medical therapy, you should generally empirically try to treat for both when it is difficult to differentiate between these two. So metronidazole, you treat at a dose of, at a higher dose actually as a 750 mg 3 times daily for 7 to 10 days. So if there is required, you might also add a luminal agent. What we generally, we don't have paramomycin. Uh, we have, I'm not getting the name now. I'll check something to for the intestinal agents. Okay. And the pyogenic abscess, you have empirical antibiotics with ceftriaxone, or generally we use for augmentin or piperacillin tazobactam. Yes, diloxanate furanate. Yes, that is a 45-year-old farmer who presents with a 7-day history of fever, headache, fatigue, and myalgia. He reports working in fields and has recently removed ticks from his body. So, on examination, he had a temperature of 102 degrees Fahrenheit. There is lymphadenopathy, hepatosplenomegaly. Laboratory tests reveal leukocytosis, elevated liver enzymes, and thrombocytopenia. So, this is a classical case of an scar that can be seen in a case of scrub typhus. So, central necrotic black area with peripheral edematous raised lesions. So, this is a characteristic of an scar. Next. So a 25-year-old male who underwent emergency splenectomy following a motor vehicle accident, he presents to the outpatient clinic 2 weeks after discharge for follow-up. He is asymptomatic and seeks advice on how to prevent vaccination following removal of the spleen. So ideal situation, you need to vaccinate whenever your splenectomy is planned electively, vaccination should be done before. But here, in case of an emergency splenectomy, like in case of an RTA, you can advise vaccinations later. So, the important vaccinations against capsulated organisms are pneumococcal vaccination, meningococcal vaccination, Haemophilus influenza vaccination, and next, also important for malaria, that you recommend prophylaxis or frequent treatment. So increased risk for capsulated
Yes.
organisms, malaria. Yeah, and these are. I think
Yes, sir. So this is our last question, sir. Yes.
yes. Thanks.
So any questions from anybody? I think sir has presented it quite well, and we have discussed most of the common questions which can be asked in your OSCEs to help the students there in your exam. So we'll be also sharing this video with you all. So in case anybody of you have missed it or you want to share with people around you, which can be useful for them as well. If you have any comments or any doubts, any questions, you can always comment in our comment box there. We'll try to solve it as soon as possible. So, thank you, sir. Thank you, Dr. Niren, sir, for your time.
Yeah, thank you. Thank you, everyone. So all the best for your exams.